Hi. Well, again, thank you for joining me today and for agreeing to answer some questions for me as part of my free event that I'm running on my Facebook group. I'm really keen to support people as much as possible, and there's always a lot of questions kind of on the medical side, so it'd be great if you could answer a few of those.
hmm hmm
Before I
hmm
ask you those questions, are you okay just to introduce yourself, because you'll do much better
Yeah.
than I would do of it.
Okay. Okay. So I'm Martin Debono. I'm a consultant gynecologist working at Calderdale and Huddersfield NHS Foundation Trust, and I'm the medical director of Yorkshire Fertility. Yorkshire Fertility being our fertility service that we run for patients around our area.
Yeah, and also the consultant that helped me as well, which is brilliant.
Yeah.
Why it's so nice to still be able to talk to you about it. So again, thank you for your time, and I'll just ask you a few questions if that's all right.
Yes.
So firstly, when a patient comes to see you, how do you decide which treatment is best for their individual case? What things do you look at to make those decisions?
So for me, the most important thing is taking a detailed history. Because fertility is a bit like it's like a bit of police work to start with. We're trying to find out, dealing with a couple, where the problem lies, because until we try and identify where the problem lies, then we have no chance of trying to fix it. So detailed history is really important, and there are certain factors in the history that are so simple to get, like women's age, like how long they've been trying to conceive. These are factors that affect people's chances of conceiving. The other important reason for taking a detailed history and then doing standard investigations is because, for me, the most important thing to do before offering treatment is ensuring that the treatment we are offering couples offers them a better chance of success than doing nothing.
Yeah.
And sometimes doing nothing may be the best treatment.
Okay. What way?
So, for example, if a couple who've had no problems at all come to see us after 3 months of trying, and they're a young couple, it is highly likely I haven't got treatments good enough, apart from telling them, keep on trying, come back in a year's time.
Okay.
But if the same couple come back to see us and the gentleman has had, or the lady has had tubal disease, and they've been trying for 3 months, then it's pointless continuing to try, because they're going to require some therapy.
Okay.
So that's why I think the history and investigation is crucial. I mean, our investigations are relatively simple. We do a semen analysis on the gentleman, and we expect the GP to have done that. We do an assessment of ovarian function, which it requires a hormone called FSH, LH, and estradiol, and that needs to be done in the first 3 days of the cycle, of the menstrual cycle. And we do an ultrasound examination on the lady. We also check the lady's rubella status, and that's just from a public health perspective, and whether she's actually been exposed to chlamydia. And those are the basic tests that we actually perform on individuals.
Yeah. So that would then determine which route you would... Which
path to go down, yeah.
Oh, okay.
And then there are some more detailed investigations that we would perform if we identify issues or not. We may decide to do a laparoscopy or a hysterosalpingogram. We may decide to do a prolactin or thyroid function in ladies who've got no periods, for example. Now, so there are different investigations, but normally the bog standard routine investigations that everyone gets are those that I've mentioned.
Okay. Great. And in terms of age then, what is the upper age limit for offering treatment, and how does age affect fertility?
Okay. So we've got certain red lines that we would not cross. So we would never treat a couple for IVF with their own eggs, for example, beyond the age of 45. And that is because no one gets pregnant beyond the age of 45 with their own eggs and IVF. So it would be wrong for me to offer that. We would never treat any woman beyond the age of 50 with any treatment.
Okay.
And that is a standard that we've set internally within our own unit, within Yorkshire Fertility, because we're not here to cause issues further on along the line. So the likelihood of someone enjoying their family at the age of 70 when a child is at age 16 or 17 or 18, whatever, and the likelihood of them seeing their children to independent existence before they pass away naturally becomes less likely. And so we've made a cutoff of the age of 50. The NHS, however, has made a lower cutoff for IVF, and to be eligible for IVF, NHS-funded IVF, you have to be below the age of 42.
Okay. But
age does affect fertility, and it does affect fertility tremendously, and that is female age, unfortunately, not male age. Male fertility starts getting affected beyond in your 60s, 65, 70. But female age is significant, and beyond the age of 30, there does start to be a decline in ovarian function. Beyond the age of 35, it starts accelerating. And so I think the public nowadays are conscious of that, or more so conscious of age-related issues, and we're certainly seeing that.
Yeah. And you say there's a cut-off at the NHS of 42, but you still offer it to 45. Do the NHS cut off purely for the fact that success rates are?
Yes. So it's a return thing. That basically they want value for money. So they want to increase the number of babies they get for the investment that they're making, and one might argue that's not unreasonable. Having said that, it's a bit arbitrary because a 35-year-old lady may have the ovarian function of a 44-year-old, of an average 44-year-old, you know. So for example, a 35-year-old lady may have decreased ovarian reserve. I've got young ladies who've been menopausal at the age of 21. Menopausal. Now, you think, oh my God, that's shocking. But that happens.
Yeah.
So that 21-year-old is acting like a 50-year-old.
Yeah.
You know?
So then is it a personal thing that you have to make a judgment then on their success rates, whether you then suggest that
spot on.
they're
Absolutely.
using eggs earlier? What would happen the other way around if you had a patient that was, say, 45, say, who had who had an ovarian reserve, like a younger lady? Would you still recommend that she use donor eggs, or would you?
Okay. So we've had that, and there is flexibility. Okay. You know, so we would always advise that the older you are, you ought to get this test called anti-Müllerian hormone, AMH. And that is because it's the most accurate way, bar going through IVF, to measure your ovarian reserve.
Yeah.
Invariably, however, a 45-year-old's AMH is going to be very challenging. And if it isn't, and surprisingly it isn't, then we are prepared to actually take them on. But again, a 45-year-old's success rate is still low for the simple reason that they are 45, and it just, I'm afraid, comes physiologically with the territory.
Yeah. Okay, thank you. That's great. And then, so age does affect fertility, but then also weight does as well. So I know there is
Yep.
an upper and a lower limit on BMI.
There
Could you
is.
explain how weight affects it? Because I know a lot of people sort of feel that it's another barrier to cross, but it is because of success rates, I believe.
Yeah, yeah. So it is another barrier, and it is quite challenging because the NHS IVF weight restriction is with a BMI of 30 or 30 or below, and that is quite challenging because there's no doubt that average BMIs in the UK have crept up and crept up and crept up, and some people do find it really difficult to lose weight. But there is a rationale behind weight and live birth. So the chances of a live birth is increased if you are within those parameters of a BMI between 21 and 19, 20 and 30. The chances of miscarriage are higher the weightier you are.
Right.
You know, and as I keep telling a lot of couples is, I'm not here to get people pregnant. I'm here to get them to have a live birth.
Yeah.
And there's a gap between those two. You know, it's really quite painful to get people pregnant and then see them miscarry for themselves and ourselves.
Oh, yeah.
Also, there are problems in pregnancy, both maternal related and fetal related. Risk of diabetes in pregnancy and other morbidities, high blood pressure in pregnancy increase. So I do support that cutoff. Having said that, and I'm going to contradict myself slightly here. Having said that, we've set our cutoff for NHS IVF at 30 because we've had to, and those are the regulations. But for any other fertility treatments, including self-funded IVF and clomiphene citrate, ovulation induction, etc., we've set our cutoff at 35. And that is partly because of what I mentioned earlier, that we are getting bigger. People are finding it more difficult to cope with weight reduction. Yeah. We have, however, invested for many, many, many years, and we're proud to say we're one of the very few in the country that do this. And we have our own fertility dietitian, who run, and Emma runs a weekly clinic, and we do encourage people to access that service for Emma to support them through their weight reduction or weight increase sometimes, you know, if they need to put some weight on.
Yeah.
So we've done as much as we can, and as flexibly as we can to accommodate people, but we would not treat anyone with any fertility medication if their BMI was greater than 35.
Okay, right, thank you. And is there anything that couples can do to increase their chances of becoming pregnant naturally or getting pregnant through fertility treatment as well?
So we do try to major on this as well, and our nursing staff are really well versed in trying to educate couples from the first day they get to us in lifestyle choices. And lifestyle is really important. There are issues with smoking, drinking alcohol, heavy caffeine drinking, heavy caffeine intake, that people can make their choices on. It doesn't mean that we have to live like, you know, in cloistered and not go to the pub and not enjoy a glass of wine with our meal. Of course not. Everything in moderation. Smoking for us is a no-no. You really need to try stop smoking, both for your general health and because nicotine does actually affect both sperm and egg function. People need to be aware of Zika and holidays and Zika areas, and we point people to the public health laboratory website, because the Zika infested areas are constantly changing. Weight, as we mentioned earlier, is really important. So I think there are a number of things that couples can do to help themselves as much as we can try and help them. But it does require lifestyle change.
Yeah, it does mean making those changes. And as you mentioned, you've got a dietitian on hand who can help with that.
We do to guide them through that. There are some things that we have. There are some things that are really, really important, and we take the welfare of the future child really, really in the center of everything we do. Strangely enough, more importantly than the couple sat in front of us. So we have a big responsibility to ensure that if we are helping you to get pregnant, that you are not going to be a potential risk to that future child with the lifestyle that you live with. Now, that doesn't mean that if you smoke, we're not going to treat you. Of course we are going to. But if, for example, I'm not going to be an extreme here, if, for example, you are a child sex offender, we would never treat you, because it is highly likely you are going to cause harm to the welfare of that future child. If you've had children put into care, we would investigate to see why those children have been put into care. So we do make sure that the welfare of that future child is paramount.
And that's all covered in your information gathering at the beginning.
Absolutely, and we make that perfectly clear with couples that we ask the GP about those issues, etc., of people who know you better than we do.
Okay. A big question that often comes up is about all the add-ons that are available. I'm sure you get asked about them a lot. There's mixed research on things. Is there anything, what are your views on the add-ons, and is there anything you do recommend people?
So I have mixed views on add-ons. I think there is emerging research on some add-ons that are beneficial. And in that category, I would put endometrial scratch for recurrent implantation failure. I think is going to prove to be of benefit. I believe the embryoscope is a major breakthrough in embryo culture. And I think it will prove, and already there are a number of units that are showing different success rates in couples who have used the embryoscope. There are other add-ons, however, that still need more research before we start offering them as routine. And offering them as regular parts of the service. Things like embryo glue, and I am a bit uncomfortable about the word itself, because clearly it gives the impression that it increases the gluing of that embryo to stick to the womb lining. Things like chromosome testing, aneuploidy testing of embryos prior to transfer. That can have some limited benefit in couples who are constantly having a combination of infertility and recurrent miscarriage. And that is because we know for a fact that the commonest cause of miscarriage is chromosomal abnormality. And if we can actually identify the chromosomally normal embryos to replace, potentially it might reduce our risk of miscarriage. But it's not of proven benefit at the moment. Okay. So we don't tend to offer these treatments as a first line. We only really offer them if we feel that our back's against the wall and there's nowhere else to go. The other one is, pardon?
Sorry, does that apply to all those add-ons? You would use them as after a first?
Tend to, yeah. So endometrial scratches recurrent implantation failure. So by definition, they've had treatments beforehand. Embryoscope again, and these add-ons can be quite expensive, can't they? I mean, they really can add up to virtually a further cycle, and that's the discussion that couples need to have. Is it better not to have add-ons and have a further cycle to maximize my chances, or just to have add-ons? So it is complex, but we certainly do not promote add-ons, but offer them with those disclaimers that there is no proven benefit for a significant number. The other add-on that gets peddled is the immunology testing, and there's a number of couples who have had natural killer cell testing and other immunology testing, based on the fact that if they have them tested, then they have various protocols of intralipid, of steroids, etc. And again, there's no proven benefit for these add-ons.
Okay, so you feel still there's not enough proof yet to warrant that. Okay, brilliant. So I guess then each one will be taken on a case-by-case basis.
Case-by-case, very much so. So it's not a routine for us to offer add-ons, but we have offered add-ons as part of a broad discussion and couples understanding that there is no proven benefit.
Yeah. Okay. And in terms of the patients you see in your day-to-day work, is there anything that you feel patients should be aware of, or some, when they're coming in for fertility treatment, that you've advised them?
So I think the biggest one for me, because it's really causing a lot of disappointment, is I'm not quite sure there is an awareness out there about the effects of Zika travel.
Okay.
So if, for example, a couple is trying to get pregnant and they're coming to see us and they go to the Caribbean on holiday, we would not be able to treat them for at least 6 months after they come back from the Caribbean. And that's for the gentleman coming back from the Caribbean. Yeah. So, and that causes a lot of frustration for couples because they've gone on holiday and now they're being sort of quarantined. So I think it's people being made aware of those restrictions, I think is really useful. And the other one, and I think more and more people are getting to this now, is age.
Yeah.
And age is so, I cannot emphasize the importance that age has. And the reason being, it's an unfixable. As soon as an age-related fertility issue is apparent, then it's an unfixable. I cannot improve your success beyond you being a poor responder. Yeah. And so I think couples who are trying to plan for a family need to bear that in mind, because it is such a major factor.
And is there anything, because I know from the groups I've had, people have talked about various things they can take or herbal type things that can help. Is there anything?
So we don't encourage multivitamins apart from 2, and that is folic acid and vitamin D. Okay. So we encourage everyone should be on folic acid.
Yeah.
400 micrograms, but if they have a BMI of greater than 30, we encourage them to have folic acid 5 milligrams,
Right.
and that is a prescribable tablet.
Right.
You can't get 5 milligrams off the counter.
Okay.
It's got to be prescribed.
And they need a higher BMI is higher.
If the BMI is greater than 30, we encourage folic acid 5 milligrams.
Okay.
If the BMI is less than 30, female BMI is less than 30, they can just get an off-the-counter product of folic acid 400 micrograms. And vitamin D, okay? Proprietary preparations of vitamin D. Boots do a combined preparation of folic acid and vitamin D. Just 1 tablet a day. 1 tablet a day of the 2 is sufficient.
Okay, so you wouldn't recommend some of these
thiamine or zinc or anything else is unnecessary.
Yeah.
Unnecessary.
Okay.
Folic acid and vitamin D, they need to take it religiously.
Right. So that is important then.
Very important. Very important.
Okay, well, just to finish off, I'm conscious of your time. What would be your top tip or recommendation for somebody who was trying to conceive then or going through IVF?
If you're set off in a relationship and you're trying to conceive, I think the first thing is have a go. Don't worry about it. Have a go. You're absolutely right. Have a go. But be aware of seeking advice sooner rather than later, depending on your circumstances.
Okay.
So if, for example, your partner has had a vasectomy and then a reversal, and it's just not happening, seek advice.
Yeah.
You know, if you know you've had chlamydial infection, seek advice. If you don't have periods, seek advice. So I think that's the first thing. The other thing, advice can be gained from so many different sources, like what you're setting up, Sarah, you know, and the fertility support group, the various blogs and Instagrams, and you know, so you can get advice prior to referral from various sources. And we're more than prepared to offer advice to couples through those media, because we have to respond to those media even without referral, you know, genuinely. We don't have any issues there. And the other piece of advice, get as fit as possible, because to get as fit as possible will improve your own natural chances. And that means age, alcohol, caffeine, smoking, you know, just look in your reflective mirror and see what you can do for yourself.
Yeah, that's great. And I know one thing I do often say to the group is just check with the clinic on things, because it's all right there being a lot of advice out there, but it's also being careful what advice you do take, because not everybody is a medical professional.
Exactly.
It's worth checking with yourselves if there's something they are concerned about, which would you advise just to be cautious of information as well?
Yeah. Good. The other thing I wanted to mention is, because some couples feel really frustrated. They go to their GP and sometimes the GP is loath to refer them. Again, seek advice, drop an email to us. We do take self-referrals if they wish to do so. We may well then send them back if we feel it's inappropriate, or if we feel they're a bit too soon, you know. But they can access our service whenever they fancy it.
Yeah, that's brilliant. Oh, well, thank you so much.
You're welcome.
I really appreciate it and your time. That's been great. And I know you've said that you'd be happy to answer questions again if there's anything else. So
definitely. I think there's a great medium, isn't it? And thank you, Sarah, for what you're doing to increase awareness, because what you're doing is absolutely incredible.
Thank you. I really appreciate that. I think it's definitely, there needs to be more awareness. I know how I felt, and the more support there is and awareness, the more people will get support. So thank you. Your team are brilliant. I obviously think the world of you all. So thank you for your time, and I know
Thank you very much.
Thank you very much. Take care, and I'll speak to you soon.
Bye,
Bye.
bye, 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 bye.